Yes, it is. Hey, Sergey, Uzo, good morning.
Good morning, Dr. Paz. Welcome back.
Thank you very much. Appreciate it. Let me see here. Share screen.
Good morning.
Ooh, hello. Good morning. Okay. See Josie O'Toole there. Okay, we'll get going in just a moment. Okay. Let's see here. What we got here? Yeah, I think all our fellows are here. Super. Okay. Good morning, everybody. All right. Let's move on to. So this is a tracing that Dr. Kong was kind enough to share with me yesterday. This is a 2-day-old who's in tachycardia for 3 hours at an outside hospital. And the patient has received adenosine, according to the story, twice, which, according to records or what she was told, briefly brought the heart rate down to 180, and then the tachycardia immediately resumed. And this is a 12-lead ECG that was obtained on this patient. So I guess the question is, what is the mechanism of this tachycardia, if you were to guess, and what would be the treatment? And let me, when I go to Dr. Babia here of New York
Good
City
morning.
and Russia. How are you?
I'm very well, thank you. How are you?
I'm well, thanks.
So looking at the rate, it's about 300.
Mm-hmm.
Tachycardia, narrow complex tachycardia. I am trying to locate the P waves before HQRS, and I believe I do see some positive reflections that I could consider P waves. But the axis is extreme right.
Okay. What do you think about a right axis in a 2-day-old?
That's normal.
That's right. This is a normal axis. And is this a wide or a narrow QRS?
Well,
if you were to describe it to someone who doesn't have a fax machine or a phone or any technology to send the tracing.
Right. To me, it looks narrow.
That's,
because
I would agree. It's like it's certainly less than even a single box, right, on the EKG. So it's a very narrow QRS.
So I would say it's either. So I'm a bit confused whether those are actual P waves before the QRS or they're not.
Where are you looking? Which lead circuit?
So it's, for example, look at the well, let's say in lead 2, it might look as P wave, but then if you look at V1, it looks more like T waves rather than P waves.
Okay. I mean, let me ask you, I'm going to take the pointer. You can see my pointer, right?
Yes.
On the screen. Okay. So where I'm pointing right now, is that what you're referring to?
Yeah.
Okay. So does that really look like a T wave to you? Are T waves usually, first of all, wouldn't the QT interval be like 80 milliseconds if this was T wave? And are T waves usually this pointy like that? What would cause I mean, unless you're hyperkalemic, you would not expect the T waves to be like that. And hyperkalemic T waves are usually actually very tall, so oftentimes taller than the QRS complex themselves. So that is not actually a typical T wave for a hyperkalemia.
So then I would say that this probably is either retrograde P wave going after the QRS complex. So then we can look at the RP interval and see that it is maybe 2 cells. So that's 80 milliseconds, which is more than 70.
Right.
And that will bring us to the diagnosis of ORT.
That's right. So that's very well stated. So when the R to P interval is greater than 70 milliseconds, usually that's ORT. Could also be an atypical form of AVNRT as well, but most commonly is ORT. And which is more common in a baby anyway? So you have a 2-day-old. If you were just going to say statistically, which would be more likely to be the case in a newborn or a 2-day-old, ORT or AVNRT? Which do you think is more common?
ORT.
ORT is probably 2/3 to 3/4 of the SVTs in newborns, but it isn't more than that. So AVNRT can certainly happen. So a couple of points. First of all, if somebody ever tells you the heart rate is close to 300 with a narrow QRS in an infant this young, in your mind, you should be thinking of the differential diagnosis. Could this be atrial flutter?
Could this be atrial flutter?
Well, let me preface by saying anything could be anything, but how would you say that this is not atrial flutter? Because this is not consistent with atrial flutter. How would you? Why is that? What is the heart rate?
Based on the rate?
Well, okay. What about the rate? That's a good way to start.
I believe flutter should be faster.
Faster in the atrium or in the ventricle?
Well, actually, I would say flutter is probably, the rate would be between 250 and 350. So this technically then could be a flutter.
Well, I'm going to stop you there. In babies, usually the atrial rate in flutter can be 500 or even faster. And so normally there's 3-to-1 or at least 2-to-1. And so actually atrial flutter rates in newborns are usually roughly around 200 beats per minute. Okay. So actually the ventricular rate in atrial flutter in a newborn or a 2-day-old would be substantially lower than this. So when you're seeing a heart rate close to 300, although I'm not saying it's impossible that the patient could have atrial flutter, maybe you could have an atrial rate of 600, although I'm not really sure the atrium can go that fast with 2-to-1. When you see a rate this fast that's approaching 300 beats per minute, you should be thinking about ORT or AVNRT, not atrial flutter. When you're seeing a heart rate of about 200, you should be thinking more in the lines of atrial flutter or atrial tachycardias like EAT or chaotic atrial rhythm or something along those lines. Okay, so that's really the teaching point I'm trying to make. The other point I would make to you is, and I've made this point a number of times, so I apologize to those of you who've been on this conference so many times already. But as you know, I think repetition is helpful for this type of stuff. If you look in lead V1, you rightfully pointed out that the P waves, the retrograde P waves, are extremely easy to see. And in fact, as some of you remember, I've said this a few times. Many years ago, we published a paper in which we took the 12-lead ECG of a series of patients that we ablated and whom we knew where the pathway was located. We knew the mechanism of tachycardia, and we basically had two electrophysiologists review the single leads of the EKG, and then compared the diagnosis that the electrophysiologist made to the actual known diagnosis based on the intracardiac electrophysiological study. And what we determined was that V1 was the best lead to see retrograde P waves on the 12-lead ECG, and the second best was lead 3. And I mention that only because, of course, traditionally we look in lead 2 because it looks the most like a standard EKG. And I'm not suggesting 2 is a bad lead, but actually we found that if you added V1 to lead 3, the doctor was wrong only like 5% of the time, or maybe even less, 3% of the time. So a good clue is to always look at V1 and 3 when somebody is in tachycardia. And again, I'll also mention that this ECG shows you how helpful it is to have a 12-lead ECG when somebody is in tachycardia if the patient is stable. In this case, the patient was quite stable. And the reason I'm explaining why it's so important is because if you only had V4 to V6, it's almost impossible to see what's going on with retrograde P waves. Some of the limb leads also are similarly very challenging to interpret, but having the 12 lead is very helpful because you have a smorgasbord of 12 leads to search for clues for the mechanism of the tachycardia. So always, 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 if the patient is stable, and that's a very, very important proviso, but if the patient is stable, always get a 12-lead ECG, okay? And certainly always get it before you call the electrophysiologist in the middle of the night. Okay, now, so the patient is in an outside hospital that is not familiar with complex arrhythmia managements, okay? And they're asking you, well, what should we do, doctor? We gave adenosine twice. We don't have any tracings of it, but believe us, it went down to the 180s for a few seconds, but then immediately went back up. So what would you recommend to these doctors?
And I would suspect that they've tried the vagal maneuvers already, right? Before giving it.
Right, but let me ask you something. What do you think happened when they gave the adenosine and it briefly brought the heart rate, say, to 180?
Well, they kind of delayed the conduction through the AV node,
right?
And that brought the tachycardia down.
Well, it probably terminated it, right? I mean, because let's presume this is ORT, and because the RP interval is 80 milliseconds or greater than 70. If the tachycardia went down to the 180s, the chances are that the tachycardia broke and then restarted. Okay, so because how does adenosine work? Of course, it blocks the AV node transiently. And so if the tachycardia restarted, a vagal maneuver would probably not do anything different than adenosine, right? In a vagal maneuver, we're trying to stimulate the vagal nerve in order to cause transient AV nodal conduction slowing, which should also potentially terminate the tachycardia. But if an AV nodal blocking agent, a transient AV nodal blocking agent like adenosine terminated it transiently, then I think it's not unreasonable to try a vagal maneuver because sometimes you just get lucky, but we would not necessarily expect that it would work any better.
And this EKG that we are looking at now, this is after they gave adenosine or before?
This is after, but they did not unfortunately do a tracing when they gave the medication. This is just a tracing that was obtained, um, you know, a
After.
few hours afterwards. Yes.
So
But this represents the heart rate that they were dealing with.
so the patient is still in RT.
Patient is in tachycardia, and according to Grace Kong, according to the referring doctors, it looks stable and has a reasonable blood pressure and perfusion. Let me ask you this. How long do you have before things are going to go south in a patient who has a structurally normal heart? In tachycardia?
24 hours. You mean the tachycardia-induced cardiomyopathy?
Yeah, rough. I would say that's right. About 12 to 24 hours. So if they're right that it's only been 3 hours, if the patient looks all right, you have a little bit of time to play around. So what would you do now? So you try a vagal maneuver, and let's say for the sake of discussion, it works, brings the heart rate down to the 180s, but then it comes right back up.
Can you try beta blockers?
Okay, yes, you can. How would you, which beta blocker would you use, and how would you administer that beta blocker?
Propranolol?
Propranolol, okay. How would you administer that medication?
You mean the dose or the route?
The route.
I would administer it. Well, if the baby is looking fine, as you mentioned, I guess oral.
That's right. You would really try never to give IV propranolol. It can cause hemodynamic embarrassment. The dose is extremely small. It can cause problems. So I think if you need an IV agent, propranolol would almost never be the one you would want to use, in my experience. So you could give oral propranolol, but that would probably take a couple of hours to effect, right? What would oral propranolol do, by the way?
Slower the rate.
How so?
Because it's beta blocker.
Right. So it's affecting what part of the limb? We have two limbs, right? We're going down the AV node and then presumably up an accessory pathway.
Yeah, that's a good question. I guess it will.
Usually it causes AV nodal slowing. That's usually the mechanism. So you could do that. Are there any any other medications you could give IV?
Digoxin?
Right. You could give digoxin. How much would you give?
I don't remember the dosing.
Okay. So in olden times, they used to digitalize patients and, to load them up. And usually you would give like 7.5 or even 10 mics per kilo. And you'd give it like every 8 hours. There's all different kinds of mechanisms for slow digitalization or rapid digitalization. But I often say that if anyone ever needs digoxin that rapidly, it's usually a good sign that they need something else, because digoxin is a very weak antiarrhythmic agent. And if you need somebody that fast to have control of the rhythm, I would not rely upon digoxin. And digoxin is potentially toxic. So in this case, Grace and I decided to, since the patient was in a community hospital where they were not as familiar with fancier antiarrhythmic agents, we decided to ask them to give one dose of propranolol, and they gave like the equivalent of 1 to 2 milligrams per kilo divided Q8 as a one-time oral dose, and we asked them to give 5 mics per kilo IV of digoxin. And I believe, Grace, you said that it just terminated eventually after about an hour or two. Is that right?
That's right. Mm-hmm.
Yeah. And in fact, let me just show you. This is the patient's electrocardiogram after the tachycardia broke. And we see that the heart rate is 128. Is there anything about this ECG? Like, why do you think the P waves are so tall? So it suggests right atrial enlargement, right? When you see these types of big P waves. Why do you think they're tall? Mr. Dr. Surkey.
Yeah, I'm trying
Just
to figure it out.
contemplating. Yes. Well, it's probably a reflection of the fact that the patient was sitting in tachycardia for 3 or 4 hours. You can get right atrial enlargement. I don't know if you recall, but recently we had a patient who shall remain nameless who had fetal tachycardia and came out of the womb and was in sinus rhythm. The mother had been treated with flecainide prenatally to treat the fetus. And the question was, should we start antiarrhythmic therapy? And I was on the consult service and I said, yes, I would start antiarrhythmic therapy. And the reason I did that was because of this observation of these tall P waves, which to me suggested the possibility that the fetus, although not in tachycardia since birth, had probably been in tachycardia in utero, at least intermittently. So that's sort of a soft sign. Now let's say, let's say that we are at Mount Sinai, which is not a community hospital, but instead a quaternary care hospital. So you've given, you have other agents. You don't have to give digoxin or propranolol. And by the way, just as an FYI, in olden times, and this is before I was a doctor, but probably in the 1980s, it was very routine to give a patient like this digoxin and then just put them in the corner and just let the digoxin work over 6 to 8 hours. But in the present era, since adenosine became available in the late 80s and early 90s, we're so used to instant gratification that everybody gets very upset when a patient remains in SVT. And so we always seem to want to get to terminate it immediately. So what other medicines, I'm going to we'll ratchet this up. Okay, you've done a very admirable job. Why don't we ask your colleague, Dr. Barris, who's on the line. So there's a national digoxin shortage, let's pretend, and a national propranolol shortage, and the patient is still in tachycardia. So how else could you manage this, David?
Well, first I would want to make sure that the IV is in the right arm when they're using, if they use the adenosine again, just because it has such a quick half-life.
Why are you making an emphasis on the right arm? I
They say
assume you
that's the
mean versus
shortest.
the left arm, but
Right. I mean, theoretically, they say that's the shortest distance for the adenosine to travel.
okay, that might be true, but you remember that the innominate vein is a very large vein from the left subclavian vein, and I think the distance is fairly similar. So I agree with the general principle that the closer to the body, to the heart, the better, yes, and you want to have a nice big flush. But again, if the story is that the adenosine did break the tachycardia transiently, clearly the route of administration was not the issue. Right. When tachycardia resumes, presumably the patient had another PAC or something like that. And that's very common, by the way. People with SVT, you give adenosine, it will transiently break and then it will restart again. So that's the story. The patient, let's say the patient is transferred here. You go, you get your IV, you put a nice big 20 gauge IV in the anticube of this 2-day-old. Everybody is amazed by your technical skill. You give the adenosine, it breaks, and it comes right back again. So now what are you going to do?
So otherwise, other medications we can try then we talked about our shortages of propranolol.
That's right. We have a national fake shortage of propranolol and digoxin, but I will of course
amiodarone, I believe, is another option we can use.
Okay, you could use amiodarone. That's true, but is there any concern you have with the use of amio? What should be your we're talking IV agents here. So what would be your biggest concern if you were considering amio, which is a very reasonable choice, but what do you want to make sure about or watch for?
Thyroid, side effects is one.
Okay, thyroid is concern, but it's not your concern in the emergency room or the ICU, because thyroid problems typically occur after a number of weeks on a medication. Any other concerns?
Trying to specific ultralight derangements that I'm worried about, but
so the most important thing that I'm hinting at, and I'm sorry, I enjoy playing this guess what I'm thinking game, so it's not very fair, but Amiodarone can cause cardiovascular collapse, particularly in newborns and small infants. And so IV amio, although a very effective medicine, is potentially very dangerous. And the incidence of that could be as high as 5%. Now, you can give it very, very slowly. Original descriptions of amio, and if you look in PALS, it says to give 5 per kilo over 20 minutes. But we almost never do that in somebody who is stable. And so you could give it like over 2 or 3 hours. Some people give 1 per kilo over 10 or 20 minutes, and they wait to see for effect. Then they give another dose. And a lot of people who do that will say that oftentimes you can get away with maybe only 2 per kilo. So you could do that, but you have to be concerned about cardiovascular collapse, which is not something that doesn't ever happen. Also, I might add, IV amiodarone is extremely sclerosing to veins. So thankfully, because of your technical skill, we have a 20 gauge IV in the right arm. So we don't have to worry about that, but it is definitely a concern. And when someone's getting IV amio peripherally, they need to be monitored very carefully, the IV site always. Okay, so it turns out that when you call the pharmacy, they've also run out of amiodarone. So what else could you try?
Flecainide is another one I've seen in the past use.
Yes, you could use flecainide, but flecainide really only comes as an oral agent. So yes, you could give the patient a dose of oral flecainide and put them in the corner and wait for it to take effect. That's not unreasonable. Any other options? Any other IV options?
I'm trying to recall Sotalol has IV as well.
That's right. And for those of you who may, on rare occasion, listen to my podcast, there was a paper that we reviewed 2 weeks ago out of the group in San Diego in which they administered Sotalol to, I believe there were 9 children who had failed adenosine in whom they tried IV Sotalol, and it was effective in all 9 patients. So that is, and they were giving a dose of 30 milligrams per meter squared as a single dose given over, I think, 30 to 40 minutes. So, and they surmise, or they believe, that this may suggest that it is a very good agent when adenosine fails. So yes, Sotalol is a possibility, but again, I'll remind you that that paper only had 37 total patients, and there were less than 10 patients who had ORT. So we can't really draw any large conclusions, but it is certainly encouraging that IV Sotalol would work. And then the last agent would probably be IV procainamide. That also would be a reasonable option to try. And actually, if I was taking care of this patient and the patient were at Sinai, I probably would have given IV procainamide, because procainamide has great direct effects on the accessory pathway, which can cause block in the pathway to terminate tachycardia. It also, if given slowly and in small doses, like 5 per kilo over, say, 20 minutes, rarely causes hypotension and has very minimal negative inotropy. So that would be my own personal bias, but there is no correct answer. So when the patient, the patient now is in sinus rhythm. So now Grace is being asked by the emergency room or by the doctors at the referring hospital, what do they want to do? What does she want to do for this patient? So David, you now are in sinus rhythm. You're breathing a sigh of relief. The patient has actually received one dose of IV digoxin and received 1 dose of oral propranolol as well. What would your choice be? What could you use as a chronic therapy? Well, let me first take a step back. Does the patient need chronic therapy? How's that? Let me ask that question first.
I would say yes, because we've shown that they have some sort of accessory pathway that can conduct. And if we're going to send them home, then we want to avoid them going back into their abnormal rhythm.
I agree with that answer. And that is a question that comes up very often, surprisingly often, by NICUs and emergency departments. If somebody had SVT, that means they have a mechanism for SVT. And because you're in sinus rhythm doesn't mean it's gone away. And so the only time that we generally don't treat people, at least I don't, is when a person is a very premature infant and is in the NICU and is going to be monitored for a few weeks or months. In those cases, it's not unreasonable to say, well, we do know that pathways will ultimately stop conducting at some point in a large percentage of patients, so it's not unreasonable to consider observation without therapy and then starting therapy if tachycardia recurs. But you're right. If the patient, this is a 2-day-old, otherwise healthy patient, so presumably in another 2 or 3 days, the patient's going to be discharged home. So if you had tachycardia on Sunday, I think it's reasonable to assume you could have tachycardia on Thursday. So yes, I would definitely treat this patient at least for a couple of months. And what therapy would you choose, Dave?
An option that I've seen used to.
You're breaking up a little bit, David. I don't know if others are having trouble hearing you.
Yeah, let me try again here. So I've seen propranolol used as an option for outpatient.
Yeah, so propranolol is a great idea. Has reasonably good efficacy, very safe agent. Just have to worry about a little bit of hypoglycemia, which is usually transient or doesn't happen at all. So the short answer is any therapy is effective. Okay, so there are so many medicines, and really any of them work, and it tends to be very style oriented. There are doctors who will use digoxin as their first agent, doctors who will use propranolol. Some places, I remember reading a paper many years ago from Ireland where they used amiodarone. And the reason they liked amiodarone was because it was a once-a-day medicine. It's very inexpensive, surprisingly easy to get, particularly in the developing world. Not that Ireland is, will be characterized that way, but the bottom line is there are many different ways to skin the cat. And so now the mother is asking you, David, all right, doctor, I'm very nervous. My baby has tachycardia. What is the future for my baby? Does my baby have to be on this medicine for the rest of her life? What's the treatment? Or what's the plan or the expectation?
I would say that we would wait for the baby to get bigger and then possibly do an EP study.
Okay, that's possibly true, but what is the likelihood if someone has SVT, let's say, as this case is at 2 days of age, what's the chance that this tachycardia is going to go away by itself over
Um,
time?
is it 40%? I'm not 100% sure.
So the answer is about 2/3 of the time SVT will resolve by a year of age. Okay. And the patient will never clinically have SVT again. And so, and that's the reason, that's one of the many reasons that you will almost never or very rarely see us do ablations in babies under a year of age, and why we always try aggressively to manage these things with medicines, because we are hoping that the natural history of SVT in an infant will be on the favor of the infant, and that will avoid ever having to do any invasive testing at all. So when a baby has SVT, it's common to tell the mother or the father that their child has a very good chance of this self-resolving, and that the reason for medication is to simply control the tachycardia while the pathway can still conduct. Okay, and so that really is, an important aspect of this. Now, there are some studies that suggest that if you have WPW as a baby, it may be more in the 50% range, a little less likely it's going to go away, but even WPW patients can lose pre-excitation and pathway conduction. So we would normally, give the family a fairly optimistic outlook of how things are going to be. And most electrophysiologists will treat for at least 6 months with arrhythmia medication. Some will treat for a full year. I think somehow I think I remember Eric Silver at Columbia wrote a paper a few years ago showing that, I might be misstating this, but I think by like 9 months, almost no one recurred who was never going to recur. So My personal bias, and this is completely made up, is I usually will dose adjust the medication until a patient is about 6 months of age. And if they're not having any tachycardia at all, then I'll usually, at that point, allow them to start outgrowing their medicine. And then sometime between 9 and 12 months, I'll usually stop it. And people have done studies looking to see which agent is best. And there is no real right answer to this. There was a study not long ago looking at a comparison between digoxin and propranolol, because those are the two most old school common agents used. And I believe that study showed no significant difference in terms of efficacy of those agents. So there's no real right answers in this. It's really very much a style issue. But I think it would be fair to say most electrophysiologists and most cardiologists use propranolol in this setting. Okay, I think we've beat this case to a pulp.
Can I ask a question, Dr. Pass, about
Yes,
digoxin?
Grace Kong, of course.
For the digoxin, we often don't use digoxin in patients that have accessory pathways.
Yes.
For this patient, is there, how did you know before looking at like a baseline EKG, looking at just his tachycardia, that digoxin would be okay?
Right. So what you're referencing is the fact that people with Wolff-Parkinson-White syndrome, digoxin could potentially be dangerous. Is that what you mean, Grace?
Yes.
Yeah. So when people have WPW, theoretically, digoxin can enhance accessory pathway conduction. And were a patient to go in atrial fibrillation, potentially you could take a pathway that cannot conduct rapidly, antegrade, and make it a dangerous pathway. So yes, there are some who would never. So the first thing to say is, beyond a year of age, it is contraindicated to use digoxin in patients with WPW. But because atrial fibrillation is so uncommon in newborns, particularly in children under 6 months of age, there are certainly many cardiologists who will use digoxin as an AV nodal blocking agent or slower in order to treat this type of problem, even in the setting of WPW. So you're absolutely right. In tachycardia, I could not tell whether the patient had pre-excitation or not, but I elected to use digoxin with you because, first of all, I thought one dose was highly unlikely to cause a problem. As I said earlier, there are many usually older cardiologists who feel very comfortable using digoxin in small infants. If you look at the literature on babies who die suddenly on digoxin with WPW, it's extremely small. There are very, very rare case reports of it, but it's very uncommon. And that's probably a reflection of the fact that it is very difficult for a baby to have AFib. Some people theorize that the atrium isn't large enough to sustain atrial fibrillation. I think that's been debunked as true. I think, though, it is certainly true that it's harder for a baby to have atrial fib than an older patient. It's probably not impossible. So the short answer is I did not know whether the patient had WPW, but I decided that even if the child did have it, one dose wasn't going to harm the baby. I did not start digoxin chronically in this infant because I personally think it's sort of a weak antiarrhythmic agent. And sometimes people are intermittently pre-excited. And my view on this is that although it is extremely rare for an infant to have a problem on digoxin, even with WPW, given the theoretical risks associated with it, it doesn't seem to me to be it doesn't seem like we need to use digoxin for a newborn with SVT for chronic therapy if there are so many other agents. So my own bias is to not use digoxin in infants treating chronically for SVT, but I certainly think it's very reasonable. Lots of people do it. There's nothing wrong with it. I just kind of feel like, why would I use an agent that has even a theoretical possible problem if I have 7 other agents that might work equally well or maybe even better that don't carry that particular risk? And remember, the reason that doctors don't use it or use it is because all those other agents have their own risks too, right? We know, for example, if we started the patient on sotalol, we can prolong the QT interval, and that could be potentially dangerous. If we start them on flecainide, the dosing can cause proarrhythmia. We've seen many cases of people getting toxic doses. Amiodarone can cause I think David commented on thyroid problems and other problems, lung, liver. So there's no free ride with any of these therapies. So, you just sort of have to pick your poison, as it were.
Mhm. Thank you, Dr.
So
Pass.
that's how I
Dr.
make it.
Pass, sorry, just one last question. Do you
Yes.
echo all the patients who come, even if it's just like you're saying, just one episode of SVT, you study meds anyway, do you echo all the patients who?
That is an excellent question, Dr. Uzoma Obiaka, Chief Fellow at Mount Sinai. Yes, I echo every patient who has SVT. And the reason that I do that is because I want to be sure that the patient doesn't have Epstein's anomaly. If the patient has a completely normal physical examination and a normal ECG, I would still do an echocardiogram. In this case, we don't need one for the perspective of function because we know the patient was only in it for 3 hours. This happened in the hospital, so there's excellent documentation of precisely when it started and when it ended. And as we discussed earlier, it would be very unusual for an infant to get into trouble for tachycardia for 40 minutes. I'm sorry, for 3 hours. However, I personally do an echo, or at least ask for an echo in most patients who have SVT. Occasionally one will slip through that we have not echoed, but generally speaking, I think it's a good policy to perform an echocardiogram at least one time to rule out any congenital heart disease. We know that Epstein's is more common in patients with SVT, also certain forms of L transposition, although of course the ECG would look totally different if that were the case. Hypertrophic cardiomyopathy is more highly associated with accessory pathways. So there are disorders that can be, particularly the Epstein's is the one that concerns me the most because you can have mild Epstein's and not know it. And it's important because if somebody had Epstein's anomaly, I would be more pessimistic that the tachycardia is going to go away. We discussed a moment ago that newborn infants who have SVT will, 2/3 of the time, they will stop having SVT by a year of age. I think that for children who have Epstein's anomaly, that is unfortunately not the case. As you know, they are associated with multiple accessory pathways. And so I would be somewhat concerned that they would have more recurrences. So in terms of predicting the future, also, if you look at this ECG, there is right atrial enlargement, right? Now, we discussed that is probably due to the fact that the child was in tachycardia for 3 hours. But it also could be due to the fact that the child has Epstein's anomaly. I don't think the child does. But yes, I would normally echo people who have SVT. All right, the next topic is going to actually take a while to review. And since the conference is ending in 4 minutes anyway, why don't we do an early ending for today? Sorry, we only reviewed 2 EKGs, but these were 2 very important ones. And thanks for joining me. And I'll see you in just a few minutes at sign out. So good to see everybody. Happy to be back.
Thank you, Dr. Pass.
Take care, guys. Be well.
Thank you,
Thank you.
Bye.
Thank you.